Hey everybody, I wanted to give you guys a quick little week one quiz review that covers chapter 1, 2, 4, and 7. So I know we go in a lot in depth in the lecture, however, I'm going to hit on some key points really. So understand that pathophysiology is simply the study of the functions of the human body in a diseased state, right? Excuse me. So we talk about like anatomy, it's going to be like the study of the structures. Physiology is the study of the normal functioning. However, patho is going to be study of the functions of the body in a disease state, like I mentioned, right? So when we look at the framework of pathology, you have to understand etiology, right? So etiology is basically the study of the cause or the reason of the disease, right? So basically what caused it, right? That's what we're talking about when we're looking at etiology, right? Now, when we look at the different classifications of diseases, it could be idiopathic, right? Idiopathic means the cause is unknown, right? Or it could be a iatrogenic disease, right? And an iatrogenic disease is a disease caused from the results of unwanted or unintended medical treatments from, for example, like surgery. Then you have like infectious diseases, right? A disease that's going to come from some type of infectious agent, such as a bacteria or a virus or a fungus. When we look at risk factors are simply factors that, when present, increase the likelihood of a disease. It doesn't mean that you're going to get it, right? But it does increase the likelihood of an individual getting a particular disease. So when we look at the stages of illness, right? So remember the stages of illness, right? And I'll keep it pretty simple. If we're in that latent stage, right? That latent stage is the time between exposure of your tissue to that injurious agent to the first appearance of signs or symptoms, right? So in that latent stage, right, that beginning stage, there's no symptoms yet, basically, okay? If it's like an infectious disease, then we call that the incubation period. So the next stage we have is the prodromal period, right? That prodromal stage, I guess. And so this is the time during which the first signs and symptoms appear, indicating the onset of the disease, right? So these is where you're going to have those early symptoms in prodromal. Okay, and I'm going to hit on another stage, and that's going to be that subclinical stage, right? And that's when the disease is present, but the person is not going to be experiencing harsh symptoms, okay? Be mindful of symptom versus sign, okay? A sign is going to be a objective or observed manifestation of the disease, right? So you can observe like a fever, you can observe like a bruise on someone's skin, but a symptom is something that's only going to be really felt by the patient, right? So if I'm the patient, I feel fatigue, or I feel nauseous, or I feel I have a headache, something like that, right? So symptoms are what the patient feel. A sign is what you can see. And again, remember these stages of illness, okay? When we look at epidemiology, it's just simply the study of the pattern of diseases involving populations, right? So remember these different types, however we're going to classify. So we can classify diseases as an endemic disease. Endemic diseases are going to be native to a local region, right? Then we have an epidemic, right? And so an epidemic is where that disease is spreading to many people at the same time, sometimes fast, right? And a pandemic is basically on a larger scale. There's many epidemics, or an epidemic everywhere, basically. Similar to like how COVID was, right? It was almost everywhere. When we look at the levels of prevention and some examples, so here are the levels of prevention, right? We have primary prevention, secondary prevention, and then tertiary prevention. Primary prevention is going to be associated with altering the susceptibility or reducing exposure for susceptible persons, right? So examples of primary prevention is vaccinations or immunizations, right? You're about to go off to college, right? Or I guess, like a typical 17, 18-year-old, they're about to go off to college and they're going to receive a meningitis vaccine, right? So that's going to be an example of primary level of prevention, right? Or even you're going to go to a health education campaign, okay? Reducing exposure. Then we have secondary prevention, And that's going to encompass like early detection, screening, and management of the disease, right? So examples would be cancer screening, right? Or blood pressure monitoring, right? Or a routine mammogram, right? To detect early stage breast cancer, okay? But it's screenings and things like that. Then we have tertiary level of prevention, and that's going to be rehabilitation, providing supportive care, reducing the disability, and restoring effective functioning, right? So this is after the disease, right? So an example of tertiary level of prevention would be post-stroke therapy to regain motor functions, right? So physical therapy, or we can have a person with diabetes, right? Prescribing them, insulin for management of their blood sugar levels, right? Or if a person has a heart attack, right, prescribing some type of drug to perhaps keep their cholesterol low. When we look at homeostasis, right, whenever we think of physiology, right, one of the main things you think of is homeostasis, right? Trying to maintain a stable internal environment, right? And that's really making sure all of your systems are in balance, right? For homeostasis, we're really going to control parameters such as like osmolarity, temperature, pH, nutrients, water, calcium, sugar levels, blood pressure, things like that, right? So trying to maintain a, stable internal environment. That's what homeostasis is. That's what we're trying to, constantly maintain and achieve. Allostasis, right, is going to be the, overall process of adaptive change really necessary to maintain survival and well-being. So it's a body's successful ability, right, to adapt to challenges, like I mentioned, to maintain survival and well-being, right? And allostasis, your adaptation, it really is vital for survival during stress. Now, when we look at allostatic overload, right, so you got to remember this as well. Allostatic overload is going to be the inadequate adaptation mechanisms or an excessive allostatic load resulting in your inability to maintain homeostasis, right? Maybe you have been, exposed to multiple stressors back to back to back to back. You're unable to adapt to the stressors, and then it could lead to long-term chronic disease. Now, when we look at the body's, stress response, and when we look at the general adaptation response, these are the three stages, right? So you got to remember these three stages, okay? So the alarm stage, right, is going to be that first stage. That's going to be, your immediate response, right? Your fight or flight, okay? Right. So in the alarm stage, right, your fight or flight is going to happen, right? This is where your body is going to essentially put some energy in your body, right? Put some energy for you to, in a sense, like fight, right? So in the alarm stage, your heart rate might spike, right? You might be like in a near miss accident and your heart rate just goes up, right? For the resistance stage, right, this is where your body tries to stabilize and cope with that stress, right? You're trying to adjust to some type of stressor. Maybe it's like a demanding job or something like that, and you're trying to adjust to that prolonged stress. Now, you're trying to resist the stress. In a sense, you're trying to resist, death, really. Now, if you can resist, you can stabilize and cope, you can bring your body to recovery. Now, if you're not able to recover, in that alarm stage, is persistent, right? That stress is persistent, right? This is where we have exhaustion, right? The breakdown of your compensatory mechanisms, right? That could lead to, permanent failure of systems, and even death is possible. Okay? But we have to understand that general adaptation response really, it helps us to maintain a normal function in spite of the stressor. Okay? So remember all of these stages, okay? And let's just look at stress, right? The body's natural stress response. And so when that hypothalamus picks up stress, it's going to, and let's just simply look at this hypothalamic pituitary adrenal axis right here. Right? So we already know that the hypothalamus is going to release these hormones in order. So the hypothalamus is going to release Well, I don't know why I put H, right? But the hypothalamus is going to put, oh, that's why I put H, right? The hypothalamus is going to release CRH, right? Corticotropin releasing hormone. That's going to go down to the anterior pituitary to release ACTH, adrenal corticotropic hormone. That adrenal corticotropic hormone, remember, this is our tropic hormones. That's going to go down to the adrenal cortex, right? So you can release cortisol. And cortisol is going to be a type of corticosteroid, right? It's going to be that stress hormone that we typically talk about, right? And cortisol is really going to do everything that it possibly can, number one, to prevent hypoglycemia, right? It's going to stimulate gluconeogenesis as a result, right? You have other things happening too, really to put some of that sugar into the blood so you can act, right, in a stressful situation. Also, we have to think about and stress our sympathetic pathways as well, right? So we're going to release, for example, epinephrine and norepinephrine. And you got to also remember what are those effects are going to do to the body, right? Increase in heart rate, right? Allowing more air to come into your lungs, right? Dilation of your eyes. So allowing more light to enter your eye, right? So remember the stress responses in general. Now, when we look at some cell injury, right? So let me talk about reversible cell injury first, right? So when we look at reversible cell injury, so remember these two different types, right? So we have hydropic swelling. Hydropic swelling is the cellular swelling attributed to accumulation of water. So water is rushing into your cell. Why? It results from a malfunction of the sodium-potassium pump. Now remember, that sodium-potassium pump requires ATP, right? But if there's no ATP, it will result in sodium accumulating inside the cell, and wherever there's sodium, water is going to want to follow. So water is going to follow and rush into the cell is going to swell up, right? However, it is reversible. Another type of reversible cell injury is intracellular accumulations. And this is where you have the excessive accumulation of substances in the cell, right? Maybe you have too much fat or adipose tissue in the cell. Okay, and also another example of intracellular accumulation is the accumulation of just abnormal substances produced by the cell because of faulty mechanisms or faulty metabolism or synthesis. Okay, so remember that. Sorry, let me go back. So when we look at cellular adaptation, so you got to remember these different cellular adaptations as well, right? So this is like your normal cells right here, okay? And when we look at atrophy, atrophy is a decrease in cell size, right? So your cells get smaller, right? And so say, for example, you're at the gym, right? You're working out constantly, right? But then you stop going to the gym, right? So your muscles will get smaller, right? Because the stress is not on them as much, right? When we look at hypertrophy, right? So hypertrophy is where you have an increase in cell size, right? So that cell gets larger really due to increased workload on it, right? So here we have like cardiac hypertrophy from like hypertension. So you can look at this left ventricle right there. Look at how large that left ventricle is. And I should have put a regular picture of the left ventricle. It's not that big. And the problem here in that, left side heart ventricle hypertrophy is, look at the lumen. Look how small the lumen is. The whole purpose of the heart is to pump blood. It's not going to pump that much blood when that lumen is so small, right? So that's an issue. But remember, hypertrophy is an increase in cell size, whereas hyperplasia, right? Hyperplasia is going to be an increase in cell number, right? So an example of that would be like the uterine lining thickening due to, hormonal stimulation. We have metaplasia, so you got to remember this too. Metaplasia is where we have a conversion of one cell type to another. So you're replacing one cell type with another cell type. So an example of this would be, like we talked about, smoking-induced replacement of those columnar cells in your airways with, squamous cells. Because squamous cells, they're able to deal with, the stress that smoking is going to induce, right? More so than your columnar cells. So metaplasia is where you're going to replace one cell type with another. When we look at dysplasia, right, this is that disordered growth or the disorderly growth, right? These cells look disorganized. And whenever you think of dysplasia, think of these as these pre-neoplastic cells, right? These pre-neoplastic cells that could turn to be cancerous, okay? When we look at cell injury, right, we have necrosis and we have apoptosis, right? So let me talk about apoptosis first, because apoptosis is, a normal physiological process, right? Apoptosis is programmed cell death, right? So if the cell is no longer needed, it's gonna activate basically like a self-destruct, right? A self-destruct pathway resulting in its regulated, underline that, regulated cell death, right? Now, apoptosis, we have different pathways, extrinsic or intrinsic pathways, right? Now, I do mention here the internal pathway, right, is going to be governed in part by P53, right? I won't go so much in depth with it, but it's that P53 that kind of ensures that it's basically like a checkpoint so cells won't continuously replicate, right? Again, apoptosis is programmed cell death. Necrosis is going to be cell death as a consequence of ischemia or toxic injury. Now, remember what ischemia is, right? Ischemia is just simply a blockage of blood flow or an interruption of blood flow to an area. So a certain area is not getting blood. If it's not getting blood, it's not getting oxygen, right? Excuse me. And when it's too severe, it's going to result in cell death, right? Now that cell may rupture, spilling out its contents into the extracellular fluid. As a result, the person will feel localized pain, inflammation, things like that. Now, I also want you to remember and understand the types of necrosis. We have coagulative necrosis. Remember, this is going to be the most common, right? Now, this coagulative necrosis is really going to be due to ischemia, right? We're going to find this type of cell death in the heart, right? We have liquefactive necrosis, right? Liquefaction of lysosomal enzymes and that form abscesses or cysts. We're typically going to find this in the brain. We have fat necrosis, right? Death of adipose tissue. We're going to find this in the pancreas. And you have caseous necrosis, right? You'll find this typically like in the lungs, okay? Neoplasia simply refers to new growth, right? More so than likely, we now really refer to the implication of abnormality of cell growth or a tumor, right? Now, when we look at these different terminologies, benign growth is generally, easily cured, right? Whereas malignant neoplasm or neoplasms, that's going to be cancer, okay? So, benign, not as scary, right, as malignant, okay? So when we look at the characteristics of benign versus malignant, right, benign tumors, they do not invade adjacent tissue or spread to distant site, meaning they are encapsulated by connective tissue. That is indicative that they are localized, right? They're not going to invade other tissue or spread. These benign growths, they're going to grow very slowly. They're going to have little vascularity. They rarely have necrotic areas, and they're going to often retain function of that normal origin tissue, okay? Now, when it comes to malignant tumors, right, these are anaplastic tumors with abnormal cell size and abnormal cell shape, right? These malignant tumors, this is what we dislike, right? They have the potential to kill the host, of course, if left untreated, whereas benign tumors do not. These malignant tumors, they're going to grow rapidly. They may initiate vessel growth, right, angiogenesis in the tumor, and they frequently have necrotic areas and are dysfunctional, right? I'll give you an example of like a malignant tumor, bronchiocarcinoma. And so remember these terminologies too, right? Typically we say like oma, right, is going to be like the benign, but when we look at the carcinoma, right, carcinomas, that's going to refer to malignant epithelial tumors. Sarcomas are going to be malignant connective tissue tumors, and adenomas will be benign glandular tissue tumors, okay? Now, we also got to understand the difference between proto-oncogenes and oncogenes, right? Proto-oncogenes are simply normal genes that code for normal proteins, okay? Again, proto-oncogenes are normal genes. However, when we get to oncogenes, these oncogenes are essentially mutated proto-oncogenes causing uncontrolled cell proliferation, okay? When we look at tumor suppression, right, we have tumor suppressor genes, right? These tumor suppressor genes will code for tumor suppressor proteins that will stop division of mutated cells. So as a result, these tumor suppressor genes, they basically act like a checkpoint. They inhibit cell proliferation, keeping most mutations from developing into cancer. Sorry. Now, I also wanted to talk about the p53 gene again, right? The p53 gene. This is going to be like the most common tumor suppressor gene, right? That will inhibit cell cycling. Now, typically we normally have a little bit of p53 found in your cells. It will accumulate in response to cellular damage, specifically DNA damage, right? And what p53 is this protein is a transcription factor that binds to damaged DNA and regulates a lot of different genes, right? Essentially what it does is it stalls cell division, allowing time for DNA to repair before DNA replication occurs in that S phase. However, too much damage, p53 will direct the cell to initiate apoptosis, right? So it's basically a control mechanism, right? But defects in this p53 function will disrupt this important quality control system, right? Allowing genetically damaged and unstable cells to survive and continue to replicate, right? I also want to hit on, just lastly, chemotherapy, right? So chemotherapy is going to kill rapidly dividing cells, right? However, we do risk the, infection and immunosuppression, right? We also have tumor markers, right? And these tumor markers are going to be able to, these are indicators really used for diagnosis. I want to end with grading versus staging, okay? So you have to understand the difference between grading and staging. So grading will refer to the histological characterization of the tumor cells. It's basically a determination of the degree of anaplasia, right? That lack of differentiation, right? What does it look like now, right? Probably doesn't look like that normal cell. And the more it doesn't look like that normal cell, the worse it is, right? And then we have staging. So staging will refer to the localization, or the location, I should say, and pattern of spread of the tumor, right? So how far did it spread, right? That's what we're looking at staging, right? It doesn't involve biochemical testing, though, of the tumor, okay? So you got to also remember that, okay? That's going to be done by cancer grading, okay? So again, understand the difference between grading versus staging, okay? Happy studies.